Hello and welcome to the group room where we're at the 34th annual CTRC-AACR San Antonio Breast Cancer Symposium. So now I'm joined by Dr. Leslie Botnick. Dr. Botnick is a board-certified radiation oncologist practicing at the Center for Radiation Therapy in Beverly Hills, California. You're also the co-founder and medical chief officer of Vantage, Oncology. This is a multidisciplinary meeting, so at this meeting you've got radiation oncologists, you've got surgeons, you've got medical oncologists, you've got the whole spectrum, researchers involved in oncology, breast medicine. There was a brachytherapy presentation. Can you tell us a bit about that?
That's partial breast radiation. It could be done by external radiation. It could be done where you put a catheter, surgeon puts the catheter in. It's a surgical procedure, a surgical fee, where they put the catheter in, is expanded, and then you go to the radiotherapy department and they use what's called high dose rate radiation, which is a source that goes into these tubes twice a day for 5 days, and that's intracavitary brachytherapy. So you're getting some additional surgical procedure because the tube is being placed, and you're getting radiation twice a day for 5 days, and it just treats the quadrant of the breast. And why I mention that is that many years ago there was a Veronese study who did quadrantectomies. And initially everybody said it's exactly the same, except the breast doesn't look as good. Well, 10, 15 years later, they found out the recurrence rates were actually higher and survival differences occurred. So I think we sometimes need to temper some of the use of newer technology and try to understand that we were just talking about breast cancer, that's multiple ducts. It's not just only in one area.
And the brachytherapy study that you were just speaking about said that it's associated with a twofold increased risk for mastectomy complications. Why?
Well, they didn't explain why, but usually I assume it's because of recurrence somewhere else in the breast. That data hasn't been refined because it's a Medicare blind study. It doesn't tell you why. So there is a study, I think the RTOG and SABCS is doing a study that's looking at partial breast irradiation. So we'll eventually find out that answer. But the point is to study. And with the chances of getting this in the community where it's not under a study controlled situation could be as high as 20%. You got to say to yourself, well, maybe we shouldn't be doing it that much, and we should be doing it under study control.
What's the future, do you think? Where are we going with research in radiation therapy?
I think even from the meeting, people are trying to do less, okay? And by doing less means, can we do less surgery? So can we figure out what to do based on biologics? So in negative estrogen receptor, progesterone receptor, HER2 negative patients, can we just do an initial biopsy and maybe a sentinel node or not, and then give neoadjuvant chemotherapy, switch chemotherapy if it's not working, use radiation earlier, in the sense never taking an axillary dissection and just removing the primary tumor after neoadjuvant. These are all things being discussed here.
Thank you, Dr. Botnick. Dr. Leslie Botnick, co-founder and chief medical officer of Vantage Oncology.
Thank you, Selma.